So what we're going to talk about is a lot of people have wondered, oh, I liked the original the AM aligner, the pink one, why'd you turn it, whatever. So what we're going to talk about is why we changed, why I like this better and went to the new, and once we got the material that we have with the new AM aligner and what's the difference. So as you can see, we got the two different ones up here, and we'll go through that. So what do? We have a simple black plane. It's thinner, more comfortable, resilient, flexible. We have irradiated thermocryl. So this is pure thermocryl, polycaprolactone, that we have irradiated. It's a polymer that's irradiated so that it maintains its shape, and it's a little bit stiffer, doesn't flow quite as much as pure thermocryl, which just turns like putty. We have a tab for people to grab a hold of, and this is really ideal for the patient, so it helps them place it in the right place. We have a little tab so that they can put it in the midline, and it guides the anterior teeth, and it provides this point for them to start with.
Yeah, and one of the things that's not really flexible, Keith, I think I would argue that word right there, because it is a rigid guide. It's not like that tab that you started with a mouth guard material. It's not another one of those. This is a rigid guide, so it can use the rigid surfaces of the teeth against this material. Now, it is a slippery rigid guide, and so it has nice smoothness to it and low friction as they
bite. You're right, and we shouldn't have put that in. It's very resilient. In other words, it can bend, but it goes back to its same force. It is not, it doesn't warp. It stays that. So you're exactly right.
Yeah. As many times as we looked at these slides, and we didn't pick up on that before. Oh, well.
Yep. So here's the original design. The material had Kevlar in it to make it tougher. It takes a perfect impression of teeth. You can make one of these and put it in 6 months later, and it fits the same. The problem is that with the Kevlar in there, you couldn't bite through it. It didn't flow well enough. It's too firm. Patients couldn't bite through it, and it doesn't get the condyle in the original position. You put anything between the teeth, I don't care what it is, unless it's mylar, you can't get that condyle disc relationship back to where they have the original contacts in centric occlusion or maximum intercuspation. So after a while, we figured this out and said, that's not really working well. So
yeah, so think about it in restorative dentistry. You go away from the big, thick articulating papers that you want to use, that you start with maybe to adjust occlusion of anything. And why do you go to the super thin ones? It's so the condyle can function in its good position, and you can mimic normal function of that occlusion using super thin articulating paper when you're checking your occlusion. So why wouldn't you want to position the jaw back in that kind of a relationship if with your morning repositioner? Same kind of principle.
So we found out that having posterior parts of this the AM aligner was too thick, so we cut it in 3 pieces and just used an anterior jig. And as you can see there, we have a bite down, and you can almost see light through. You can see light through the contacts in the anterior teeth, although the anterior teeth don't touch. You don't have contact with the anterior teeth, but you have a location of that anterior thing.
Well, sometimes you do. They put a hole in it, and that worries patients because they see a hole in it and they think, oh my gosh, it's going to break. And sometimes this thermocryl does break a little bit. And Keith, you may not remember this. This has happened a long time ago, but you and I were teaching a class down at Pankey about airway issues. And you assigned me the task to teach the class about AML aligners. And so everybody was demonstrated the full arch AML aligner like we saw in the previous slides. And everybody was just about to break up into their pairs to go make these on each other. And you walked in and said, "Oh, guys, let me show you how we're doing it now," and proceeded to cut it in thirds and talk about that. And so I asked, I said, "How long have you been doing that?" And you said, "Oh, about a week." And so that's innovation.
Yeah. Yeah.
Anyway, so my trouble with this design, and I've been doing it this way ever since that day in that clinic. And I use these AML aligners like this. I also use the beads to do the same thing. And the problem that many patients have is they can't seem to figure out how to put it on their teeth. And if their lower teeth are really crooked, it can be challenging to get it lined up just right. And so they end up breaking it, or they end up losing it, or it doesn't really look like a professional piece of equipment. I think the full arch one does. I think it looks like something that's intended to be for them. I think this little one, which works better, doesn't look as good as it should. Now, I've used it because it's so effective, but it doesn't work as well for patients who don't have a lot of overjet and overbite because there's not a lot of space to put the thermocryl. It doesn't work as good for an end-on-end bite because there's no slope to leverage against the condylar position. And so there's some limitations in making it cuspid to cuspid like this, but in my hands, it was better than the full arch one for a lot of patients. But I always had both of those tools available.
Good. So here's a patient example that I had wearing one. She couldn't fit it back on her lower teeth right. And as you can see, after 1 year, this is where it was. So she wasn't getting this back on her teeth correctly and using it enough. So we said, okay, I've got to have something better than this. So that we went on.
Yeah. And I've had patients that have rinsed this under warm water and they're holding it in their fingers and they bend it. Then it never fits correctly again. So then they abandon this therapy and they don't have the easy way to make it happen. So what's new?
So as I say, the radiated thermocryl has a little stiffness to it. If you heat it up to the correct temperature, it's easier to put in the mouth. You got this handle, patient can use it, put it in right. It covers all the teeth. And the main thing is like Steve was saying, is once you bite through it, the thickness of where you see the light through is about the thickness of the mylar strips we have. So we know we're getting right back into the same occlusal relationship we started with. And a lot of times, if you want to, you can use a second one as something that you can keep in their records or whatever to show that this was the original occlusion. So it's a kind of fun thing. A lot of times we'll make 2 of these for patients.
Yeah. And the slopes, again, the slopes of all of the teeth are engaged to direct the forces. And when they get, what we tell them is to bite gently on it at first, gently on it, increase your pressure. And then when you got it close, when you feel like those teeth are coming together, you feel your muscles correctly, then bite as hard as you want, because you're not going to hurt this. And that's really a comfortable thing to do for that. And nobody's broken one yet. Nobody's warped one. Well, yes, they have warped one yet. I'll show you a video of somebody who warped one. But so Keith, why did you put people don't like change? Because my patients don't know any different.
Well, we've had some people that have complained about, oh, I like the old one better. And so part of this is saying, okay, here's why I decided to change this. And I think it's a very positive change. And we're going to show how easy this is and easier it is, and particularly for people to be able to use it effectively and come out with the what you want to have with this. So it's a little bit of, it's like me teaching saying, well, I don't do it this way, I do it this way now. I'm just going, I just change it when it gets better, and kind of don't tell anybody. So
Right.
anyway, that's why you're on this thing, you know.